Today I'll be presenting a case of a young adult whose persistent respiratory symptoms were misdiagnosed as asthma for over a decade, until a rare and overlooked condition, subglottic stenosis, was finally uncovered. Our patient is a young female university student who came in with a long-standing history of noisy breathing and shortness of breath, particularly during physical activity. These symptoms had persisted for more than 10 years and had been attributed to asthma. What's important here is that she was diagnosed with asthma in adolescence but had never undergone spirometry. Over the years, her symptoms remained unchanged despite treatment with inhaled steroids and bronchodilators. She never experienced acute attacks, chest thickness, or a significant cough, which raised some red flags about the accuracy of the original diagnosis. She reported adjusting her lifestyle to avoid exertion, but no one had questioned why her asthma wasn't responding to standard care. Review of symptoms was essentially unremarkable except for exertional dyspnea and persistent noisy breathing. She denied any other respiratory or systemic symptoms. Her only notable past history was an endoscopy procedure with intubation at age 8, an important detail that becomes relevant later. As I said before, she was a university student who adapted her lifestyle to avoid physical exertion and didn't report any smoking use in her clinical history. No familial, respiratory, or autoimmune diseases were reported. On ENT evaluation, biphasic stridor was detected, something previously mistaken for wheeze. This prompted further investigation. Nasendoscopy revealed a narrowed airway below the vocal cords, confirming subglottic stenosis, specifically grade C, meaning a 70 to 29% narrowing. A CT imaging corroborated this finding, showing a 7 millimeters narrowing just below the cricoid cartilage. Reading chest X-rays were normal, and spirometry had never been performed, which might have earlier revealed the upper airway obstruction. So, what exactly is subglottic stenosis? It's a narrowing of the airway below the vocal cords, often caused by trauma, autoimmune disease, or prolonged intubation. In this patient case, the childhood intubation likely caused a scar that gradually became symptomatic as she grew and her oxygen demand increased. Because the narrowing didn't cause acute events or infection, it was easily mistaken for asthma, a diagnosis that stuck for years. The patient underwent microlaryngoscopy with balloon dilation of the stenotic segment. This initially improved her symptoms; however, like many cases of SGS, subnarrowing recurred within a few months, and she is currently being scheduled for another dilation. Open surgical repair may be considered if dilation proves insufficient long term. This reminds us of two crucial clinical lessons. First, always confirm an asthma diagnosis with spirometry, and second, not all noisy breathing is wheeze, especially when it doesn't respond to treatment. Biphasic stridor, in particular, should always raise suspicion for upper airway obstruction. Early ENT referral and objective testing could have shortened this patient diagnostic delays significantly. Thank you for your attention, and I'm happy to share this presentation.